Dr. Geyer, tell me about the first time you heard about the Triadyme-C disc from Dymicron, and what were your thoughts?
I believe I first heard about 8 to 10 years ago. And what first caught my eye was the materials. It was a man-made polycrystalline diamond, and basically synthetic material. And apparently it was reputed to have very, very low wear characteristics, much lower than any other materials that we have today. The other thing that struck me was this tri-lobe design, and it was unique in that previously all we had were the ball and socket variations, or we had a compressible disc that still had a little ball material in the center that was a variation of the ball and socket, but it was compressible. So in looking further about the tri-lobe, to me it made more sense in looking at some of the biomechanics of it, because the motion in the cervical spine is very complex. It's just not flexion and extension, it's just not rotation, and it's just not lateral bending, but is the coupling of all three of those motions. And in looking at the data, it seemed to me that the tri-lobe accounted for that normal motion much more so than a ball and socket.
Tell me about your practice and how many patients that you're seeing and performing motion preservation, disc arthroplasty procedures on compared to fusion operations.
Well, we actually published an article on that a few years ago, and I believe we had almost 450 patients that we were screening for artificial disc, and it turned out that 75% of patients were candidates for the artificial disc, and only 25% were not, and for a variety of reasons. Mainly it was anatomy and some other structural problem. So that's in our practice, and I think for all those surgeons that do arthroplasty, the FDA criteria are very, very specific, and that's to get the ideal patient so we can really find out what the problems are with the disc, and hopefully there are none, or if there are, then certain things that we can avoid. But now that we've had the artificial disc for 20 years, we've expanded those patients that we consider to be candidates for disc replacement. So in our hands, we look for reasons not to do the disc replacement, not to do a fusion, rather than for reasons to do a fusion.
You tell us, first of all, sort of the average age of a patient that you've seen in your studies. I know it varies greatly, but maybe give us a couple patient stories. You've dealt from high performance professional athletes to normal everyday parents or housewife or
Sure.
husband that wants to stay active.
Well, the average age is somewhere around 40 years of age. We do them in patients as old as 60, even into the mid-60s. The FDA criterion, of course, was 60, but there's many patients that are physiologically young. And for example, an older patient that before we would consider to do a fusion on, now we do artificial disc. And one patient that comes to mind was a patient who had come to me for his lumbar spine, and I examined him, and his reflexes said there may be something going on in his neck. So we did an MRI scan of his neck, and he had a massive herniation at the C5-6 level and a smaller one at C6-7. At the C5-6 level, he had tremendous cord compression. So I thought, oh, at his age, and he was in his early 60s, I thought, he's probably going to have bone spurs. So we got a CT scan, and lo and behold, it was all soft tissue. So traditionally in the past, I would have done a 2-level fusion on him. We did a 2-level cervical disc replacement. He came back, he's doing fine. The funny sensation he had of his hands and a little bit of dexterity, and even some of the leg symptoms he's having was actually coming from a cervical spine. So that's somebody that in the past we would have done a 2-level fusion, every day, day in and day out. Now that we have artificial disc, it's a much better option for him, because he also had some degenerative changes above and below. So if we did a 2-level fusion on him, maybe he would have done fine, early 60s, and depending on how long he would have lived. But it's a nice option in that we don't have to worry about the fusion to heal, don't have to worry about putting a plate in, you don't have to worry about the compression of the esophagus causing swallowing problems. So that was one case. And then, I take care of a lot of, high-level athletes, whether amateur or professional. And a typical cervical radiculopathy that doesn't respond to conservative treatment, that's not a candidate for a minimally invasive foraminotomy, you can do this surgery on, and they get back to their activities very, very quickly. It used to be said that we'd have to wait 6 to 12 weeks before they start their activities, but we will get them started much sooner rather than later.
And is the surgery a same-day surgery? Do they go home the same day, or what does that look like for the patient?
Many arthroplasty surgeons do them in the same day. We do them in what we call same day, 23.5 hour. So technically, we do it as an outpatient, but our facility is not really a surgery center, so it's a 23.5 hour stay. So it might be overnight, but they're still in the hospital less than 24 hours.
Dr. Geyer, tell us how you're involved with Dymicron.
Well, I was interested in Dymicron from the very beginning, and we just sort of kept tabs, and finally I was asked to be on their scientific advisory board as they're preparing for their FDA trial. And I was excited about this because I've been one of the lead investigators for numerous cervical artificial discs, and I like the new technology. I like the materials that it's made out of. I like the design of it, and I am really excited about the upcoming trial because we need new and better discs to come out. You never sit on your laurels. So this to me is the next iteration in terms of materials and also design. What's going to come next, I'm not sure. But right now I think that this is the latest one that's out there. And what I'm also encouraged by, it's a very, very safe material, which means that even though it's man-made polycrystalline diamond, it's basically carbon. Our bodies are made of 18% carbon, and I wouldn't expect anybody's body to respond to this material. There have been materials out there that we see the patient's body respond to, but this is not one of them. So that's why I'm most excited about it. And I'm excited about the tri-lobe design, the coupling of flexion and extension, more so than any of the other designs that are out there. And that's why, as I said earlier, from the very beginning, it just caught my eye. It made sense rather than the typical ball and socket, because our discs are not typical ball and sockets.